So EML4 ALK translocation is a small proportion of non-small cell lung cancers generally, represents about 4 to 5%. But it is again very important to pick these patients up because we've got very effective targeted drugs against these. We're now some 7 years away from the first ALK inhibitor, which is crizotinib. And we know that that was an effective drug compared to chemotherapy. However, we've now got second generation drugs, ceritinib in particular. Then we've got next generation drugs, which include alectinib, brigatinib, and lorlatinib now being the newest kid on the block. So my experience in treating ALK positive lung cancer has been quite significant because we have a large proportion of Asian population in Leicestershire. We have quite significant numbers of non-smokers who reach the service with lung cancer, and they're often carrying actionable mutations. So my experience with all those drugs has been very, very positive. In particular with brigatinib, I was the chief investigator for ALTA-1, which looked at first-line brigatinib versus crizotinib, and there were 2 cohorts of patients. They could be treatment naive and they could go on directly to having ALK TKIs, and that would have been the key that would be our main way of trying to get patients into the study. However, we know that sometimes the DNA can fail, and if there's impending symptoms, sometimes we end up starting chemotherapy early. So a second cohort of patients was people who'd received chemotherapy, and then we found out their ALK result, and they could then go on to the trial. So 2 cohorts in that study in ALTA-1. And my experience with brigatinib has been very positive indeed. You start off with a 90 milligram dose, then increase it to 180, and that really almost eliminates, I would say, the acute pulmonary events that we were first seeing when we used this drug. And it's very tolerable once daily dosing. Patients have found it extremely well tolerated. Even I had a couple of patients following chemotherapy, and of course that was a breath of fresh air for them, having progressed on chemotherapy, then going on to a targeted agent. And a significant proportion of those patients had brain mets at presentation because the trial screened for it at baseline. So those patients had to have their brain metastases treated before they went in, either by whole brain radiotherapy or stereotactics, which is local therapy to a number of brain metastases. And then they were randomized to receiving either crizotinib or brigatinib. And I'm pleased to say, and we still have a number of patients who are still continuing very, very well, despite presenting with brain metastases, having quite significant symptoms at presentation, who are now leading a very good quality of life. So generally, my experience of treating patients with brigatinib has been very positive. I can't remember any patient that I had to switch due to toxicity. There's a few patients we need to dose reduce due to side effects that we know about and that we monitor. But really, it's been very well received from both clinicians and patients.